What if I told you one of the biggest reasons women with sleep disorders go undiagnosed is because they don't look like the patients you learned about in your clinical training? Today, Dr. Audrey Wells and I are going to work through 3 patient cases. And as we go through this, I want you to think about the patients that you see in your clinical practice because the cases that we're talking about today will probably sound pretty familiar to you. If you're new here, I'm Dr. Nishi Bhopal. I'm a psychiatrist and sleep medicine physician. This channel is for you, the healthcare practitioner who wants to learn more about sleep medicine so you can better serve your patients and clients in your clinical practice. If that's the type of information you're interested in, go ahead and click the like button below and let's jump in. Dr. Wells, I'm really excited for today's discussion. We are going to be talking about 3 cases that clinicians are likely to see in their clinical practices. And we're going to talk about how you think through those cases, how you might do the workup, and then how you think through a treatment plan. So this is going to be really high yield for the clinician. Before we start, can you tell our audience a bit about your background and what you do?
Oh, sure. So I'm Dr. Audrey Wells. I'm the Chief Medical Officer of Sleep.com. That's SLIIP. And I'm really excited to talk about these cases today because they're all involving women. I am boarded in sleep medicine, also boarded in obesity medicine, and a certified menopause physician. So I'm excited to dive into some sort of atypical presentations of sleep problems in this group.
Excellent. Okay, so let's go ahead and jump in. The first case, so I'm going to tell you about the case and then I'll pause and you can ask me what other information you want to know or how you would think through the history. So case number 1, this is a woman who comes to clinic. She's 47 years old and her chief complaints are fatigue, brain fog, and trouble concentrating at work. She's also having trouble staying asleep. Over the past year, she's seen her PCP a number of times. She's had routine lab work and was told everything was normal. And eventually, her PCP referred her to psychiatry, and she was started on an SSRI for presumed anxiety and depression. 4 months later, she comes back to you. Let's presume you're the PCP. And she says she doesn't feel much better. So before I tell you anything else about this case, what is going through your mind?
The first thing is that this is such a common avatar for a woman. The age 47 kind of flags my brain for a perimenopause situation where there's going to be a lot of non-specific symptoms, but also like this anticipated escalation of symptoms. So we're dealing with a rapidly changing clinical situation here. And the point that I would really like to make if I was sitting on the shoulder of the primary care physician who's seeing her back, who's hearing that she's not helped by the anxiety and depression treatment, she still has symptoms, is to really open your mind to how an untreated sleep disorder might present. And we know that there's tons of overlap between perimenopausal symptoms and poor sleep, reduced sleep quality, or reduced sleep quantity. So kind of having that flexible way of thinking is the first point I'd like to make for the PCP hearing about some initial treatment plan that didn't really produce the results that they wanted.
So what is initially on your differential diagnosis when you hear about a case like this?
Yeah, I want to point out that it's not my impression or it's not my intention to give the impression that I'm a hammer and everything looks like a nail. But I do want to really underscore the idea that sleep problems are common. And the fun thing about sleep problems is that when you make progress with diagnosis and treatment, then a lot of things tend to get better. And so this is a really juicy area to dive into with your patient because not only will they feel seen and validated, they will also be motivated to go through a sleep evaluation and kind of attack their symptoms with the idea that they can get better. Now, you talked about a lot of things that were normal, and I think as women, that can be a challenge. You know, when you hear this is normal, that's normal, that's normal, then you start to think the problem must be with me. I'm not doing enough. And this kind of touches on like a biopsychosocial approach to sleep treatment where, you know, we really need to be aware that women will internalize that normal sounding picture and start to learn to live with these symptoms, thinking that they're just part of getting older, or I just have a lot going on right now, or this is a really stressful time for me. So I think as your patient's advocate who is savvy about the insidious ways that sleep disorders present, you can have a low threshold for referring your patient to get testing and a really thorough evaluation by a sleep medicine physician.
Excellent. Okay, that's really helpful. So now I'm going to give you a little bit more information about this case, and I'd love to hear your thoughts. We find out that her BMI is 27. Her husband says she doesn't really snore, at least not loudly. Her Epworth Sleepiness Scale score is 8. Mm-hmm. And then you decide to order a sleep study. And she comes back, her overall AHI, her apnea-hypopnea index, is 8, and her REM AHI is 22. And she also meets criteria for chronic insomnia. Now, where would you go with this case?
Yeah, so I want to commend the PCP in this case for ordering a sleep test, even when symptoms aren't kind of like all pointed in the direction of sleep apnea. And typically, home sleep apnea testing is what you're looking for when you order a home test. So the fatigue instead of sleepiness, the plus or minus snoring, the unresolved symptoms once you go down the anxiety depression route, all of those are indications for testing and getting more information. Now, you went over the test results, and this is a super common picture, right? Her AHI is technically in the mild range, and I have a whole discussion with people about the myth of mild sleep apnea. And there's a little bit of clinical nuance here, because if you take the time to look into the report and see that her REM AHI is elevated at 22, I think you said, then the informed PCP is going to realize that moderate sleep apnea is occurring in REM sleep, but the total AHI is diluted because of all the normal breathing she's having during non-REM sleep. And REM sleep only makes up about 20-25% of the total sleep time, assuming that on the night of the test, she had a very big sample size, like 7 hours of sleep or so. So now you're kind of clued in to like, this woman has sleep apnea, which is likely clinically relevant because she is having symptoms, tired, brain fog, fatigue. She's in that perimenopausal window where her risk for sleep apnea is escalating, and she's reporting problems with her sleep. So she flags on a clinical diagnosis of insomnia. So at this point, I think I want to say what I would not do as a PCP, and that's not minimize these test results, because you really want to make the impression for this woman that her symptoms are real and her test results are actually validating those symptoms. So people who have REM-related sleep apnea tend to have problems with emotional regulation, because that's one of the functions of healthy REM sleep. They tend to have some brain fog. They tend to have some issues with perceiving poor sleep quality. And there's also this really frustrating thing that happens, and I'm sure everybody who's watching this will endorse the middle of the night awakening that turns into an hour or two of sleep disruption that reduces your total night experience or your total sleep time. So that REM awakening is really problematic, because oftentimes it's with some cardiovascular instability, a high heart rate, a trigger of your sympathetic nervous system, and that perpetuates the length of that awakening to be really frustrating. So don't minimize the mild sleep apnea. Do present it to your patient as something that they can work on. And I think another way to be really ready is to be able to talk about alternatives to PAP therapy. So a common experience is you present this data to a person and they say, you know what, I hear that it's mild, maybe a little bit more in REM, but I don't want to do the mask. I don't want that thing, that machine. I've seen my husband try to struggle with it. I've seen my sister, my parent, whatever, and they have that impression. I don't want the mask. So leave the door open for alternative therapies. This woman has a BMI of 27, so she doesn't technically meet criteria for a GLP-1 GIP medication for sleep apnea, but she may do better with oral appliance therapy. She may want to try some position therapy, depending on some of the nuances of the test. She may want to first go down the road of insomnia treatment to see how much benefit she gets from that before she can think about PAP therapy or oral appliance therapy for sleep apnea. So there's lots of choices, and really partnering with the patient to help her understand that we have something to work on is important.
Thank you. Okay, that was really helpful. And Dr. Wells and I have a whole video on CPAP alternatives, so I'll link that here as well if anyone wants to check that out. We'll do another video, I think another time, on how to address the patient who doesn't want to do the sleep study because they think that CPAP is the only option. Because sometimes you might hear from patients like, I don't want to get tested because I don't want to wear the mask. And how do we deal with that? So we'll do a separate video talking about that clinical situation. But is there anything else you want to add to case number 1 before we go to case number 2?
I do want to say that there's some utility here if the patient declines pursuing sleep apnea treatment at this point. I think it's worthwhile to bookmark that in the clinical notes because this is an evolving picture. This is a situation where as she progresses into her early 50s and goes through the menopausal transition, the results of her sleep study could change in step with that. What do I mean? I mean that the patient who is perimenopausal will have an increasing sleep apnea risk, such that if you study her sleep even a year later, she could have significant worsening of her obstructive sleep apnea. And if she doesn't know about that, then you have failed to do that anticipatory guidance that is going to get her back in your office when her sleep symptoms persist. So in this phase of life, it's worth doing some spot checking, especially if her sleep apnea goes untreated, because then you could tell her, now actually a year later, your sleep apnea is solidly in the moderate category, and she'd likely see a change in category to severe REM sleep apnea, which would help her make that decision to move forward with therapy.
That's a great segue into case number 2. So let me present case number 2. So our next patient is 54 years old. Her biggest complaint is waking up almost every night around 2 or 3 a.m. And she tells you, I just don't sleep like I used to. And when you ask her, she's waking up with hot flashes, she says, well, I feel kind of warm sometimes when I wake up, but she doesn't really describe dramatic hot flashes. Where would you begin with the history and next steps with this patient? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
Yeah, in this case, at age 54, she's going to be more solidly into a menopausal situation. So I'd want to confirm that with her. And menopause is an interesting time because the day you're in menopause is only diagnosable in hindsight. So the day you're in menopause means that you've spent a year with no periods. And just about every time someone goes through a non-surgical menopause, they're going to have that change in the way their periods come, even a change in flow. But when they've spent a year with no periods, then you can know that you are in menopause. So I would want to clarify that with her. And sometimes it's helpful to get a sense of when their mother went through menopause, because there's a correlation there. So confirming that she's in menopause would be a good place to start. And she's not describing typical night sweats or hot flashes, but I do think that if she's complaining of waking up warm, that could be a stimulus for the awakening. And so talking through some sleep hygiene about making your bedroom cool, wearing bed clothing that is wicking and cooling can be helpful, and really addressing anything else that might be prompting that middle of the night awakening. As I alluded to before, middle of the night awakenings often have a stimulus for the awakening. And that 2 to 3 a.m. time period is a time when somebody is likely to have a REM period, which is often associated with blocked airway and a bigger drop in the blood oxygen level. And then when you wake up, your heart rate can be fast as a reflexive response to the drop in blood oxygen. And then that awakening can be prolonged because you've already satisfied a lot of your sleep need in the first few hours of sleep. Plus, women tend to sit there and ruminate. And, we've had this discussion before. You go over your to-do list, you second guess that argument you had, you think about the future and, what's going on with my kids? Are they ever going to launch out of the house? And you're in this sandwich generation where your parents are aging and your kids are in some different degrees of transition. So that middle of the night awakening can be prolonged, and sometimes it's worthwhile to get into that with patients a little bit to figure out if they can shorten it and then give them a better sleep experience.
Okay, so let me give you a few more data points on this case. When you do the history, you find out that she's gained about 15 pounds over the last few years. Her partner mentions occasional snoring, and she also has newly diagnosed hypertension. So, at what point do you recommend a referral to sleep, like sleep medicine clinic, or maybe ordering a sleep study? And when do you think that hormone therapy might be useful in a case like this? When is CBTI the better option if she also has comorbid insomnia? So there's lots of different treatment paths we could take. I'm curious to hear how you think through the different options and where you would begin.
Yeah. And again, if I'm sitting on the shoulder of the physician or clinician who is talking to this woman, you cannot place the order for a sleep medicine referral fast enough in this case. She needs help. She's got a cardiovascular risk factor that could be directly related to sleep apnea or even persistent insomnia. She's got weight gain, which is rather rapid, which suggests a metabolic effect of disordered sleep, and she's symptomatic. So sleep medicine referral all the way here. And really pump that patient up for going through with it, because I'm sure she's frustrated with the weight gain. I'm sure she is thinking, I do not want to take a blood pressure medication. I'm sure she is wanting to get better. And this is the perfect patient to move into a sleep medicine evaluation. And that's going to be taken care of for you. Everybody who's doing primary care right now is stretched, and they have a small visit, and opening up a sleep Pandora's box is like the last thing you want to do. That's why sleep medicine physicians exist. And I think that, there's so many vectors in this case pointed in that direction, and you could be the one who helps this patient in a really meaningful way. You asked me a few more questions, so what have I not answered at this point?
Okay, so the other things are some clinicians might consider hormone therapy in a patient like this. And so where does that fit into the picture? And if she also has comorbid insomnia, CBTI, as we know, is the first-line gold standard treatment for that. So how might you conceptualize adding that into the case?
Yeah. So I wouldn't necessarily treat her for hot flashes at this point. And, we're in a really nice time right now because there are non-hormonal therapies for hot flashes. There's Veoza or fezolinetant, and there is a new one, Linquit, which is elinzanetant. And those can be deployed by the primary care doc to specifically address night sweats, and sometimes with really beneficial results. With this woman, I wouldn't necessarily go there because her history of the hot flash isn't that convincing. But she would qualify presumably for some hormonal treatment. And I think if the primary care physician was comfortable in doing that, they could start estrogen and progesterone if she still has a uterus, or they can refer out to a menopausal care specialist. Now, there's tons of myths out there left over from the early 2000s study suggesting that hormonal therapy was associated with breast cancer. For anyone who's not caught up with that discussion, it was debunked. And so there's a whole generation of women who are kind of laboring under this myth that hormonal therapy is more dangerous than it's worth. But we are smarter now, we know better now, and so really truly, if she could get into a situation to be evaluated for hormonal therapy, that may help her as well. At the very least, I would want to see some evaluation for vaginal estrogen. We talked about the hot flashes, but that's definitely a consideration. And it may help people to know that progesterone is a hormone that causes some sedation. It stimulates GABA. So a lot of women have a good experience when they take progesterone supplementation at night. I'm talking about micronized progesterone. Estrogen, similarly, can be used. And these hormones, when they go down in the menopause, are part of what increases risk for sleep apnea because progesterone is a respiratory stimulant. It's associated with airway tone. Estrogen is responsible for that temperature stability at night and can promote sleep stability as well. So for those reasons, in addition to her symptoms, it's worthwhile for her to have a hormone evaluation.
All right, and I'm just going to name something that people might be thinking when they're listening to this if you're the clinician. So we're presuming that we've already addressed the sleep hygiene, we've talked about alcohol, we've talked about stimulants, caffeine, exercise, all, the lifestyle factors. So we're talking about, okay, let's say you've addressed those things. Now where do we go next?
Yeah. And, I think it's really great that you highlight that because one of the things that I've had so much success with, and I consider it low-hanging fruit at this point, is counseling patients on their alcohol use, which is sometimes a sort of maladaptive coping mechanism for sleep problems, right? So that ability to relax doesn't come out of the wine bottle. It comes from you creating more boundaries with your to-do list and the people who have demands on you. So, and as we age, and Lord knows I've experienced this myself, like I do not tolerate alcohol anywhere close to where I did 10 years ago. So reducing alcohol, even eliminating alcohol is really good advice.
All right, so let's move into case number 3. So here we're going to focus on a more detailed treatment plan. This is our final patient. This is the type of patient that most clinicians are seeing regularly in their practice, whether they're a psychiatrist, PCP, or another specialist. After a comprehensive evaluation, you've now identified several contributors to her sleep problems. So we know she has REM-predominant OSA, obstructive sleep apnea. She also has chronic insomnia. She's got postmenopausal sleep changes, mild hypertension, and persistent daytime fatigue. And she looks at you and she says, "Doctor, there's just so many things wrong with my sleep. Where do I even begin?" So I'd love to hear how you would think through working with this patient to build a treatment roadmap. And here we're not asking, what is the best treatment for this patient, but really how do we personalize care to that patient sitting in front of us?
Yeah, I think that's really great. And providing this insight about how sleep medicine physicians would approach this patient whose sleep really seems broken at this point is helpful because, a lot of it is just step by step validating symptoms and step by step addressing the sleep complaint that's bubbling to the top. In this case, you mentioned she had REM-predominant OSA, again, super common in women, and one of the things responsible for under-recognition of the sleep apnea treatment or sleep apnea diagnosis in this age group. So for her, I would suggest really hitting that hard. CPAP is the gold standard, but the truth is a lot of women in midlife, especially if they don't have a lot of neck mass or they have a favorable oral anatomy with not a whole lot of overlap, with a soft palate and a tongue will do quite well with oral appliance therapy. And for many women, this is hugely more palatable than the mask and the machine. So really encouraging her as the primary care doc to go forward with whatever sleep apnea treatment makes the most sense. That collaboration with your patient is important, and really targeting full night therapy is going to be important if this patient or any patient's sleep apnea is more predominant in REM, because REM is most common in the second half of the night. And I know you talk about this in your clinical sleep kit community, and a lot of other juicy pearls that if you don't know is really going to impact how that patient responds to advice. So those are some things that I think a PCP can put into action straight away. Weight gain is always unwelcome in midlife, and a lot of times in the menopause transition, that weight gain is occurring in the midsection, such that you kind of are frustrated with, how this looks, and it's like different than the way you perceive yourself. And side note, like nothing's changed with diet or exercise, so it's super frustrating. If this woman is an eligible candidate for tirzepatide therapy, she has the sleep apnea that would qualify her for weight loss medication. And that can go a long way toward helping people feeling like they're actualizing on their health. That weight loss is supported on a backdrop of good nutrition and healthy exercise habits. And so with a diagnosis of sleep apnea, at this point, she may be able to walk that back with a little bit of weight loss. Of course, you always want to remember that weight loss treatment is not necessarily curative for sleep apnea because the number 2 risk factor is age. So again, with each passing year, she's going to accumulate some sleep apnea risk with age. I think when someone's sleep feels broken, there's a tendency to retaliate against that with more revenge bedtime procrastination and kind of, going through this period where you feel hopeless and helpless for nighttime awakenings. So if this woman could engage with a brief behavioral therapy program or a CBTI program, cognitive behavioral therapy for insomnia, that would be beneficial just to feel like she's doing something about her insomnia piece. There's also a lot of apps available for relaxation and even CBTI applications. So depending on one's lifestyle, those might be more applicable. But suffice to say, this is a person who's going to need a multi-pronged approach. And in dealing with women who have multiple sleep diagnoses or overlapping sleep diagnoses, this can be quite empowering if you pace them well, okay? So sleep being a foundation of health and similar to nutrition and exercise, talking about expectations for pace can be really helpful. And the primary care physician or primary care clinician is in a place to kind of help that woman understand this is going to be a long-term project, like a year at least. But every step you take in the right direction is going to have a great payout, of an ROI, if you will, because just like every meal that you eat helps to stabilize your metabolic tendency to gain weight or not, every rep you do in the gym is going to help you build muscle mass. Every night of sleep that is a little bit more healthy than the night before is going to help you with your cardiac risk factors, your blood pressure, your metabolic risk factors, your weight gain. And I think it's really important for women to understand that when Alzheimer's dementia is like twice that of what men experience, that healthy sleep is going to protect your brain. And your brain is the most important asset that you have. So every night of sleep is a vote for brain health.
Well said. And Dr. Wells and I also we have a few videos on this channel if anyone wants to go deeper. We have a whole video on tirzepatide for sleep apnea, so you can check that out as well. For the clinician who wants to go deeper into women's sleep health, what is a resource you might recommend for clinical education and something that's reputable, even that they could share with their patients as well?
Yeah. I mean, honestly, I would recommend your clinical sleep kit as a really rich resource, not just for women's sleep health. I know that's something that you talk about a lot, but for sleep health in general. And your focus is so nice because it's like a practical way for clinicians, physicians, to implement these ideas and these practices in the visit, along with all the other things that you have to take care of. From a patient perspective, I would direct them to the programs that I have, sleep.com. I do webinars at least once a month, often twice a month, and they're free, they're online, they're virtual, they're recorded. And I think it's a really easy way for women to understand that they're not going crazy with their symptoms and there's something to be done about it. This is a passion of mine, and I've taken the time to really delve into it and make the care accessible. So if for no other reason than to feel my hand at your back to move forward with correcting your sleep, feel free to sign up for those webinars. Feel free to come into sleep.com for your evaluation, because we're here to help you. And this is the reason why sleep medicine exists, is so that we can take care of problems like these.
Excellent. So we'll put those resources in the video description below this video, and so you can check them out. I highly recommend attending Dr. Wells' free webinars. She's got such a unique constellation of clinical expertise with a background in obesity, sleep medicine, menopause care. So I highly recommend following her. All right. So if you're a clinician listening to this discussion, post in the comments below which of these cases reminded you of a patient you might be working with in your clinical practice. And if there are other case-based discussions that you would like us to do, please let us know what your ideas and suggestions are, so you can post those below as well. Thank you so much, Dr. Wells, for being here today.
It's always a pleasure. Great to talk to you.